Good afternoon, everyone. As people start continue to filter in, I just want to give a brief introduction to our visiting professor, Dr. Martin Bohus. I'm Lois Joy Kane. I'm the director of the Adult Borderline Center and Training Institute. And our Training Institute was founded through donor-funded monies to reinvest in the growth of some of the adult borderline center programming. And the first kind of outgrowth of this funding was the mentalization-based treatment clinic. We were able to get the kind of mentorship and supervision and friendship of Anthony Bateman and Peter Fonagy to establish an insurance-based, evidence-based treatment for borderline personality disorder. And that clinic has now grown to have trained over 30 clinicians at McLean and treated 60 patients who would otherwise not be able to access evidence-based care here. Now we have other donor-funded monies to expand the Training Institute to include DBT PTSD, which is the first implementation of Martin Bohus's evidence-based treatment for complex PTSD in the United States, which is very exciting. So the exciting part of this is this clinic will provide treatment that Martin will tell you the evidence for patients at McLean who suffer from complex PTSD. It will be insurance-based, and our training team of clinicians spans the Hill Center, the LEADER program, 3 East, and Gunderson program. So it's a very exciting cross-departmental effort to better service our patients in our hospital. And I want to thank Shelley for bringing the division of these clinicians together. Although it includes LEADER, it also includes many of the programs within the Women's Division of Women's Mental Health. But let me introduce our speaker, who was here 2 years ago as our Stanton lecturer. Martin Bohus is full professor in psychosomatics and psychotherapy at the University of Heidelberg and director of the Department of Psychosomatics and Psychotherapy at the Central Institute of Mental Health, Mannheim. He is also associate professor of the University of Arts at Karlsruhe, Germany. He is a distinguished figure in the field of research and treatment for borderline personality disorder and has received several awards, most notable of which is Established Investigator Award for the BPD Research Foundation, the Research Award and Outstanding Research Award from the International Society for the Investigation and Teaching of DBT, and Psychotherapy Award from the German Association of Psychiatry and Psychotherapy and Neurology. His research interests, as you will see, spans both clinical realms of treatment outcomes, but also neuroscience, the underpinnings of BPD and now complex PTSD. And he focuses on treatment development for affective dysregulation in borderline personality disorder, particularly pain perception, emotional learning, and dissociative features and trauma-related behaviors. He has authored over 80 original papers, 45 books, and numerous book chapters, and he is really a leader and innovator in our field. We are honored and lucky to have him as a visiting professor, and we look forward to hearing your talk on this new evidence-based treatment.
Yeah, Louise, thank you very much. I feel very privileged to stay here and give you the talk. I feel a little bit like at home already. It's the third time that I'm invited. Thank you. Yeah, it's mainly, as a behavioral therapist, I would say this is the second most important positive reinforcer. The first is patients get better. The second is people listen to you. This is why we do the work. So I hope that those who are coming completely from the trauma field, they say hello, they welcome me a little bit since I'm coming from the borderline field. And I'm not that familiar with all the pitfalls and intrigues and tiny little problems in the field of the PTSD world. As in any scientific community, there are some, but I don't know them, so maybe I make a lot of verbal mistakes, but just have to go through that. So when we developed this treatment program, it was very easy. The point is I'm a trainee by Marshall Linehan. I'm very closely working with her and also with Alan Frasetti. And we knew since years that if you treat borderline patients, DBT is currently the best established. However, it's far from being good or sufficient. And one of the major problems is that it has nothing to offer for patients with co-occurring PTSD. So the data show clearly that if you run DBT for a year, only 10 or 13% really remit. And this makes sense, since if you teach them to reduce their stress level, the frequency of intrusions and flashbacks is reduced as well, since it's driven by sympathetic tonus. So you have some side effects, positive side effects on that. But there's a huge amount of patients who simply don't do better, and it's clear that those who suffer from PTSD, they not only have worse outcome, but they have shown more suicidality, more self-harm, and more drug abuse and chronicity. And this is true for any of this established treatment. There's no data in none of the treatment, neither MBT nor TFP or something, how they're called. Nobody ever showed that they can treat co-occurring PTSD. And we have a lot. So it's about, in the clinical population, 60%. In the open field, about 30, around about that. So it means if we cannot sufficiently treat half of our patients, we have a problem. And this is where we started. And the second thing, we had barriers, and these barriers were more or less self-made. And one of the barriers is the dogma that you should touch the trauma as long as you have a fragile, this means suicidal or self-harming, unsafe patient. And this is the dogma in DBT, and I was preaching it as well and said, okay, first go for stage 1, look that they learn their skills and to get control over their dysfunctional behavior, that they learn control not to follow their internal thoughts and not to cut themselves and so on. And only if they are safe, then add an established protocol. That was the term, established protocol. This was where Melanie Harnett, maybe you're familiar with her, she's a very prestigious colleague, and she did exactly that way. She provided standard DBT, and after they were stable, then she added the classic PE protocol. We did it a little bit different, and this was thanks to a colleague of mine. She was educated in England by David Clark, a very strong cognitive therapist, and she came up to me and said, Martin, what to do with patients who simply cut themselves in order to reduce dissociation or in order to stop flashbacks? And I said, yeah, they can learn skills. And they said, okay, and if they don't learn them? And I said, they have to learn them anyway. And then they said, okay, I have a lot of patients who simply don't learn this since their flashbacks are so strong, and even they are not eager to do this since they have this cognitions of I'm not worth, I don't deserve a life worth living and so on, which is trauma driven. And she said, as long as we don't treat the trauma, they won't get better. And I said, no, it's the other way around. And God's sake, after a while we figured out and said, maybe this is a good research question. Maybe it's simply a dogma. Maybe it's simply a myth. Who in the world tells you that patients get worse if they are suicidal and you touch their trauma? This is simply clinical assumptions. And then we said, okay, let's test it. And what we did is, we have a well-established 3 months residential DBT treatment where we do standard DBT, and we get exactly the same results within 3 months as you usually get within 1 year. And the good thing is we have well-established and good trained nurses, so we said, okay, let's try it. Let's go and establish a really hardcore exposure therapy and include the worst of the worst. Include them even if they're cutting themselves, even if they're suicidal, even if they're drug abusing, even if they are a little bit anorectic till an BMI to 16. So usually these patients which are excluded from any trial or any established treatment. And we only could do it since we had these awards. Yeah? So what I tell you now is exactly the story of this development. And what I have to be a little bit here, so this is a closed circle. I show you data which are not published. and I show you data which are not communicated to the scientific community. This is the RCT, which is a lot of people waiting for this data, and I was considering, should I show it, should I not show it? I show it, but please don't tell it around. Is it possible here? I don't know it. I don't know you, but I trust you, okay? So, I have some disclosures. So I have some grants, and I make a little bit of money in teaching. So it's a funny thing now. I think some of you are aware of the ICD-11. Usually you're prone to DSM, of course, but the rest of the world looks on the ICD-11. And the ICD-11 ICD-10 is just revised to ICD-11, and in the ICD-11 there's a new diagnosis, and this new diagnosis is called complex PTSD. And of course it has the same diagnostic criteria as PTSD. It's not longer a subpart of anxiety disorders. The whole PTSD now belongs to stress-related disorders, which I think is good, since it is not only an anxiety disorder, there are other important emotions playing a role, and this opened the possibility to add complex PTSD. And complex PTSD simply shows here, you have the standard PTSD stuff and severe problems in the self-organization. Self-organization means affect dysregulation, negative self-concept, interpersonal disturbances. And now I give you these characteristics have to be pervasive and occur across various contexts and relationships regardless of the proximity to the traumatic remand. This means this has to be pervasive and generalized. This is what they call now, from this trauma side, the complex PTSD. And you will see in a minute that it's very, very, very hard to discriminate this diagnosis from the diagnosis of borderline personality disorder plus PTSD. Since you have the classic 4 domains in borderlines. In borderlines you have the 3 domains, as well as in complex PTSD. We have emotional regulation, self-concept, and social cooperation. And now you add the memory processing problem, which is trauma-specific. I think most of you are aware that these things are really quite evidence-based. Let's say emotion dysregulation show only a few data. The characteristics now in ICD-11 are heightened emotional reactivity, violent outbursts, reckless or self-destructive behavior, prolonged dissociative states, numbing, and also the lack of ability to experience pleasure or positive emotion. That's exactly what borderline patients show. And just to give you a few data, I will show you I will relate on that slide later, is if we look at our patients and we ask them, if you think about yourself, and we assess the related emotions. What you see here is the black bars. These are patients before our treatment, and you see the huge level of guilt and shame regarding to themselves, and also disgust. The white bars are traumatized, healthy patients. These are patients with sexual abuse during childhood without any psychiatric disorder. So you see huge discrepancies, and it's completely the entire field of emotion. But shame, guilt, disgust, self-contempt are the major players. And this is the specific emotions, but we don't have to forget that the whole emotional system is dysregulated. And you have perfect researchers here with Ken Restler and so on, who are much better than we are. And he's coming from the PTSD side, and we are coming from the borderline side. And we're just sitting together yesterday and said, "Oh, wow, interesting. We just have the same results." What we have here is meta-analysis published in 2015, where we could show that in general we have a strong amygdala hyperfunction, we have a strong increase of the amygdala, we have a blunted response of the prefrontal limbic interaction, and we also could show that what Marty Teichert is doing here, he was the first, we're just replicating his work, is that we could show that this amygdala hypervolumetry depends on the age of onset of the trauma. With left, we have now 200 assessments here. On the left side, you see more or less a pattern of the age of onset of the abuse. And what you see here is that at the age of, you have a sensitive age of around about 10 to 12, where the amygdala is the most sensitive part. So let's say if you traumatize a little bit earlier, then the hippocampus plays a major role, later on the amygdala. So there is some sort of beginning understanding that type and timing and frequency plays a role in the morphology, and we start now to investigate whether this morphology has a specific impact on the psychopathology and maybe on treatment. We also could show and know, meanwhile, that classical dysfunctional behavior, everybody is aware of these cuttings, yeah? That this cutting is very easily to understand. If we cut our patients in the scanner, you can do this, since our ethical advisory board, they allowed us. So we put them in the scanner, we stress them, and we cut them, sham and real, with a small stitch. It's not very important. And what you see here, this is the blue group, is healthies, this is our borderlines. This is the group who had real cuttings, this is the sham cuttings, and you see the clear-cut discrepancy that patients who cut themselves experience a quick decrease of the amygdala, of the tension release, and we also could show that you find it as an amygdala downregulation. So cutting means simply blunt your amygdala by self-help. And how does it work? It works in increasing the connectivity between the prefrontal areas and the amygdala. So this is exactly where the deficit was. So cutting is a very sufficient, quick-working self-help process based on simple neurobiological stuff. It makes it understandable why PTSD patients cut themselves, and even depressive patients start to cut themselves, and it's a general thing. Yeah? I think in a secondary way you can say, okay, cutting has something to do with gaining attention and so, but this is secondary. Primary is it's a neurobiological process. And the second domain is the aversive self-concept. Here, the characteristics sounds familiar for borderlines. Negative self-concept marked by persistent beliefs about oneself as diminished, defeated, worthless, and that can be accompanied by deep and pervasive feelings of shame and guilt. It took me a lot of effort to bring this in the ICD-11 diagnostic criteria for borderlines. It hasn't been in for years. And nobody talked, there was no shame and guilt, didn't exist. So now it's no difference. So, and please allow me a short conceptualization, since this is one of the core understandings how our treatment is designed. This doesn't have to be the truth. This is how we see the situation. We have the model that we think, okay, given a young kid, let's say age of 5 to 8, being continuously abused within their family, has to survive and to cope with two major tasks. The first task is really to survive. As you may know, survive it's not a guarantee in families. In Germany we have 80 million people, and we have one killed child by their parents per week. I'm sure you have more here. This means survival is a serious question in a potential harmful raping and so on environment. And actually the child doesn't know whether it survives or not. So the first thing they really have to learn is to activate the self-protective system. This is the number one. And the self-protective system has always a short consequence and long-term consequence. The short-term consequence is seeking safety, help, and so on. And the long-term consequence is to prevent the relapse. This means what can I do that it doesn't happen again? And the major tool we have as human beings is understanding why does this happen. This means automatically our brain starts to rumor, why does this happen to me? Yeah? So in order to prevent it. So kid has, first question is, why does this happen to me? And every kid has some sort of explanation. And the second thing is, kids have to stay in their family. The idea of leaving the family just comes up at the horizon at 11, 12 or something, when they start to get in the puberty and adolescence, and they have the fantasy, maybe I could live with my friends or anywhere else. At the age of 5, 6, 7, no fantasy about that. So the only point is I have to stay there. The only escape is suicide. or dreaming your way anywhere. So for that, almost every suicidal ideation runs back to the age of 5 or 6 or something, where they started with that. And but the point is, they have to stay in their family. And if you have to stay in the family on a moderate energetic level, you have to love your parents. So the trick is how to A, survive, and B, love your parents anyway. And how to do that? You need a whole bunch of complicated maneuvers, and these are the classical surviving maneuvers. And the first is, this is normal. This happens. Parents tell them, fathers do this, they have to do this. So I think kids rise up and say, this is normal. After a while, they have new friends in the kindergarten, in the primary school, and anywhere, and they get, wow, it seems to be different in other families. It seems as if this kind of sexual something doesn't happen in other families. If I try to talk with my friend, they just say, what is up? So they learn this is normal, but only in our family. And they learn there's a huge discrepancy between our family and other families, and this results in shame. Since shame always means we are different or worse than others, and this means protect your family from being seen from others. And this is what kids do instinctively. So that's the one thing. The second thing is that they belong to themselves and say, I am somehow wrong. I'm different than others. I'm wrong. This is why I deserve this. And the same, if I'm wrong, this means I'm worse than I should be. The primary emotion is shame. And then, if they grow a little bit older, they come to action. And then it comes to, I did something wrong. So it was more an action-driven emotion, and the action-driven emotion is guilt. So these are the two major emotions, shame and guilt. There comes another third emotion. This is disgust and self-contempt, which has a lot to do with contamination. If you get contaminated by sperm or something like that, you feel your body as disgustive. And since there is no discrepancy between the body and the self in kids, they feel completely as their self as contaminated. Yeah? And they start to feel themselves as disgustive. There's no discrepancy. And then they start to try to maneuver to say, this is not my body, I'm not here, and things like that. Yeah? So all this, I would say, these early splitting processes, which have been described by Otto Kernberg, they have a lot to do with escaping from a very disgustive self. Okay, so disgust maybe is a third one, and if you hate yourself and you disgust yourself, then you start, and a third emotion, this is called self-contempt. So if that comes up, and all these emotions, and I think this is essential to understand it, these are, from a dynamic perspective, you could say, these are defense lines against the experience of complete unpredictable powerlessness. Yeah, psychodynamics have the idea of defense lines, and I would say guilt and shame, and it's the first defense line against powerlessness. And this is the reason why these patients don't give up guilt and shame. And since there's always the threat of powerlessness in the back. And as long as you cannot teach them or confront them or teach the brain that powerlessness belongs to the past, and the current powerlessness is much tinier and is not that dangerous. As long as you don't teach it to them, this means expose them to their past or experienced powerlessness, they won't give up guilt and shame. So that's the theory. That's why we go so directly for exposure of powerlessness and correcting during the exposure guilt and shame, since from my experience, the correction of guilt and shame is not a cognitive intervention. It doesn't work. They say, if you start with the classic cognitive intervention and say, okay, what exactly did you do to seduce your father? Tell me how, or would every 8-year-old girl you would call it's their guilt, and so on. It ends with the patient say, listen, I know that I'm not guilty, but I don't feel it. Yeah? And then this is the end of cognitive interventions. And then you have to either go on a metacognitive cell, say, okay, this thinking shows up, don't take care, so this is metacognitive, or you go really on the basics, and this is exposure to powerlessness. This is at least our idea, I don't know whether it's correct. The point is, if somebody is driven by shame and guilt, then you pay a price. And this price is that you have, these are social emotions. And if you run around with the experience of being guilty and feeling ashamed, then you have the strong assumption that if they will see how bad I am, they will reject me, yeah? And I won't be part of the human society. So I have to hide my real existence. And so this results in what we call severe distortion of the social affiliative system. So the point is, they have two major problems. The first is the safety problem, and the second is the social affiliative problem. And if you only focus on safety or anxiety, you miss an important issue. I think everybody who's familiar with this, kids and so knows this intuitively. So you can assess this. We know that all this rejection sensitivity is a huge problem. You see here a group of psychiatric patients and the rejection sensitivity, the rejection proneness. Here's the group of borderline patients with PTSD. You think it's really, really high, even compared to severe social phobics. So if you sum it up, we say pathological guilt is something which shows up if you experience uncontrollable and unpredictable threat. Yes? Then you experience extreme powerlessness. That's normal. This, and then you have a coping strategy which makes sense out of that. This means you have a whole sort of pseudo-causal explanation. It's up to me. And then you develop what we call guilt. But guilt is growing and the powerlessness is going slower. So this is how we explain it to the patients. This is why you need guilt. It made sense former times. Okay? But the consequences is that your behavior is driven by that guilt and this, what you call, it's part of your self-esteem, this guilt feeling, yeah? So this means you behave self-contempt, submissive, and so on, and you don't go to perform or really have the feeling that you're worth living according to your values. And the last domain is social cooperation, and social cooperation is here characterized again by persistent difficulties in sustaining relationships, difficulties in feeling close to others, and and of course they have difficulties in maintaining emotional engagement. This is the ICD-11. You see, it's the same thing as borderline patients have. Where does that come from? I don't know. We have a model and a concept that we're now starting to really to investigate and to get the empirical data on that. This is just concepts. And we think that a trauma has two parts. And this is the experience of, we have now treated about 500 patients with this treatment. And I've not seen everybody in details, but I've seen a lot of them in details and doing the supervision. I think almost everybody has two problems. The one is the trauma itself. And the second is, what happened if you try to tell it to your mother or to some significant other? And both parts play together. And not really the second problem is the most severe problem. This means questions like, then you do the exposure and they tell, okay, it was this rape in the cellar, it was done, and I was lying there, I was crying there, and I didn't try to do it, and blah, blah, blah. And then I went back, and then he stops and said, okay, and how did it end? There it ended. He said, did you stay in the cellar for 24 hours? No, I went up to the kitchen. And then? Yeah, then my mother was there. Did you tell something to your mother? Yes, I tried to tell her. What she said? She said, don't tell me stuff like this. And then I asked, and then she crows in tears, and this is it. And then we say, okay, this is the top. This is the hot top. You understand? So there are always two parts, and I'm not sure, but I'm more and more moving in the direction that I even think that this is the more severe part, is losing your social context and having this harsh disappointment. We call this, meanwhile, in the DBT world, traumatic invalidation. Traumatic invalidation can happen if something really serious has happened, but it can also happen if you have a severe emotion dysregulation and you try to share something, but that's another party. So traumatic invalidation means nobody's listening to me, nobody's believing this to me, and it's a very life-threatening something, and you have the repetitive experience that intensive emotional experience cannot be shared, or ridiculed, or simply refused by important others. Yeah? And the consequences in the short term are, of course, bitter disappointment, sometimes rage and anger and severe irritation. You can imagine what that happened. Just step in the shoes of an 8-year-old girl telling her mother that she has been raped, and the mother says, don't tell me that bullshit. And she also feels a complete insecure since the social synchronicity is missing. So what we could call the social security is completely off. It's not only the trauma per se, it's this I cannot share this experience with somebody else. And on the long term, if it happens repetitively, you start up thinking like, I'm different than others, something is very wrong with me, I do not understand myself, I cannot predict my responses, I cannot trust my own guts, I'm alone, I'm different than others, I do not understand the rules of the world, there's nobody reliable out there, there's nobody to trust out there. These are consequences of repetitive traumatic non-validation. This is different than trauma. So if we come to this model, you say, repetitive experience of traumatic invalidation. Sort out and it comes with extreme irritation and the feeling of social abandonment. And you have to cope with this a little bit, since again, you make sense out of that. Every brain makes sense out of everything, and this means this is why I'm different. I'm different than other. I'm an alien. This is what we call alienation. And the emotion which goes with this I'm different than other is shame. So the consequences is I'm feeling ashamed, and then at least I have a rationale for that what happens, and this feels a little bit better. And the consequences is, of course, self-contempt, self-help, submissive behavior, and so on. So this is the model. Patients buy it very, very quickly. And the extreme is a yes, 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 yes. That's it. You understand? Okay, thank you. So, and then the third domain, disturbed memory processing, I don't have to tell you here, I just have to tell you how often it is. We assessed with momentary assessment under ambulatory conditions, it's tiny computer systems, the frequency of intrusions and flashbacks under daily life conditions, asking backwards every hour, and compared it to paper and pencil after a week. And what is found here is that patients in the medium report over 670 intrusions per week. This means 10 per day. This means macro one every hour. And you can imagine how life is if every hour some really strong intrusion shows up and costs tons of energy to stop it, to escape of that, and to cope all your physiological arousal which is coming with this. It's like a panic attack. If you have 10 panic attacks a day, you cannot do anything else. And this is a crystal clear explanation why they cannot survive under normal conditions. Yeah? And this is also clear why they like to drink and why they like to cut their blood and to take drugs and anything, just to reduce the frequency and the intensity of this thing. This has never been shown. The CAPS assesses 3 intrusions per day. That's max. And then it's over. So it hasn't even been designed for that. So we were also very impressed. So that's the treatment. This treatment targets exactly those 4 issues. And we said we need a treatment that focuses specific on the sequelae of this multiple traumatic experience, all 4 dimensions. We thought exposure per se is not enough, since this is just reducing the frequency of the intrusions. We knew that, but it's more than that. And we didn't want to exclude highly dissociative features, patients with chronic suicidality, with ongoing self-harm, with current substance abuse, and it should, of course, mainly work for borderline patients. So that was our prerequisite. So what we did is, and this is why you're sitting here, and in the next minutes you will say, oh, I do exactly the same since years, and so you are right. There's not that much new in it. It's a composition. Yeah? So, and the good thing in the world nowadays is that almost everything has already been invented in the world of psychotherapy. There's nothing that much new. And if somebody comes up and says, I have a new treatment, don't believe it. Maybe he has one new intervention. Yeah? So this is just a composition. It's a multi-modular treatment composition with algorithms showing you what to do under which conditions, which has an advantage since people from old schools can come in and jump in and learn it very easily, I hope. So we have, on the one hand, the DBT side. Since DBT gives us a very good basic, good principles and rules, and it's very good in maintaining the therapeutic relationships. It's very good in contingency management, and it's also extremely good in skills, since skills are very practical, tiny little quick self-instructions which you can teach your patients how to regulate your aversive tensions and how to regulate the dissociation. So we like it from that part. The second part, we had to add, of course, trauma-focused cognitive and exposure-based interventions. And we had to add something which is directly targeting on this self-contempt. And the best intervention I found is compassion-focused therapy, developed by my dear friend Paul Gilbert. And he's really nice in this development. It's very practical tools where you can easily train up your patients to develop a sense of compassion for themselves and for others. And from ACT, acceptance and commitment, we took the value part, we changed it a little bit and adapted a little bit. We took the acceptance part, changed it a little and adapted a little bit. So you see, we took most things from the third wave of therapy together and have a package. And this package is first designed for a residential treatment, 3 months. And secondly, designed as an outpatient treatment. This is 40 sessions plus 5 booster sessions. You say that's a lot. We say yes. However, if you treat borderline patients, nobody would dream about that you can do it within 20 minutes, 20 sessions. This is what you need, and you will see that we treat borderline patients. So the structure is a matrix structure. It's not pure DBT, since pure DBT is always driven by the diary cards or the behavior of the patients. Here, it's a mixture. On the one hand, we follow a protocol. However, whenever somebody gets really suicidal or shows up severe treatment-interfering behavior, then we pick it up, wherever they are. And as you see, we have, it's a little bit semi-structures. We have roundabout 4 to 7 sessions, skills, roundabout 15 sessions. So it hasn't to be exactly page 1, page 2, page 3. It's much more individualized. And it's a whole package where you can say, okay, I have a patient with a special problem. Usually you have a manual, a handout for this. It's very educative. We have the manual, if it's ready someday, it's 500 pages and about 150 pages, which are simply worksheets and stuff that patients work through. The whole education part is here. What to do with nightmares, what to do with your self-contempt, what to do with disgust. Lists about your trauma-typical cognitions, and so on. So it's a combination between a self-help book and psychotherapy. So the first phase, just to lead you a little bit through, you have the commitment phase, where it's nothing special, biography, then the current crisis-generating behavior, and we start very early with mindfulness, since mindfulness is extremely good training to activate the capacity to get this distance from your automatic thoughts. Then we are...
One-on-one, or is this in a group?
Yeah, thank you. It's a one-on-one. We don't give skills groups. The whole thing is one-on-one. The reason is, since patients and therapists they need only a few skills, let's say 5, 6 skills. And it's easier to give them in the individual session than to wait till they show up in the skills group sometimes. So it's only a... Thank you for the question. Please interrupt me if you have these important questions. So then we start in the very first session already with a short exploration of the trauma, what happened and so on. And then we have a very, very strong point on the treatment goals and the values. Since we say, okay, the uppermost goal of psychotherapy is to help the patients to develop a meaningful life. And so the question is always, what would you do with your life if you wouldn't suffer from this PTSD any longer? And most of the patients haven't the slightest idea what to do with their life. So that we have to have at least an idea so that they know why they're doing all that. So this is a strong motivational part where we put in front of that. I think it results in a good maintenance group. So then we have some things to cope with the difficulties in transference and transference and countertransference, where we anticipate transference problems in a way that we make analysis of significant others, and we have at least short assumptions what will happen if I would threaten you or if you would seek help for me and you don't get it. They learn just what they learned from their father, from their mother, and how would it be if that would show up in therapy. We explain a lot about the psychotherapeutic relationship in the beginning. So anticipating countertransference and transference problems, I think it's quite essential to keep them, since they're borderline patients, and of course it's complicated with the relationship. And then we start PTSD model. We give some skills, mainly anti-dissociative skills. Why? If they dissociate, they blunt the amygdala and the hippocampus. If they blunt the amygdala and hippocampus, they cannot learn. This means exposure without blocking dissociation doesn't work. It is crystal clear. For that, we call it skills-assisted exposure. This means you have to, on the one hand, push them to processing the memory, on the second hand, really to hinder them to dissociate and to keep the contact to the reality, mostly on a sensory level. So the exposure per se is, we define an index trauma. All our patients have more than 5, 6, 7 traumas. We take the worst of the worst first. Why? Since if you don't do that and you take a lower or mediocre, then brain is automatically activating the whole cascade of traumatic memories. All these traumatic memories are linked together. So if you do for, let's say, compassionate reasons, you start with a mediocre one, and you talk about that. Patients start up to develop the memory of the worst, and they don't talk about that. And they have the experience to say, oh my God, I hardly survived that one. If I have to talk about the real one, this will be a disaster. And then it gets worse. And this is one of the major mistakes often therapists do, since they have the feeling, so we go tappy, tappy, tappy a little way, and then they open the box of the Pandora and they don't know how to close it. So the trick is, go for the worst of the worst first. And we do it, start with this index, we start with a written report, then we go for skills-assisted exposure. This is strong imagination, verbalizing it and blocking the dissociation, and again taking them back and looking for learning the brain to identify sensoric stimuli in the present. They are asked to do the homework. This means they listen to these taped sessions every hour. Classic at home. Usually they are on a trainer or somewhere, or they're running stairs just to get in movement. So this helps not to dissociate. If you're running stairs, you cannot dissociate. As long as you run, you don't dissociate. So there's a lot of tricks. It leads too far. So we do 5, 6, 7, 8 repetition till the whole thing is down, and then we take the second and the third. Usually then it's okay. Use normally maximum 8 you need, normally 7, and then the second one you need 4, and the third one you need 1 session. It gets down and down and down. So that's very interesting. So the idea is not to have a narrative, but the basic idea is we expose them towards the primary trauma-related emotion. This means the emotions the patient had experienced during the trauma. And this is normally helplessness, disgust, fear, sexual arousal, humiliation, threat, and confusion. This is not shame, this is not guilt. These are secondary emotions. So you have to skip, you have to go under guilt and shame and really focus on that. This is what I say, they have to keep the patient in an optimum of emotional activation. This means you have patients who are here, very rational. You have to help them to get more emotional. If they go that level, this means they increase their level of arousal, then they start to dissociate, and their learning goes down. So you have to keep them in this corridor. Next step is acceptance. It's very important not to end with the exposure, since most of the patients still have the experience. This shouldn't have happened. And then we help them really to go into it and write it up and say, okay, this has happened to me. My father raped me from the age of 5 to 8, and I will still remember this situation the rest of my life, and sometimes I will suffer. This is how it is. It is how it is. And this, often patients have severe difficulties to write it down, read it out loud, and tell it themselves in a voice tone that they believe it to them. And this opens the window to grief. And lots of the problems of our traumatized patients is inhibited grief. And inhibited grief is opened by acceptance. And then they can start to do that. So this is this part. And afterwards we start with Regain Your Life. The problem is that this treatment is extremely successful. This means they have arranged their whole life around their PTSD. They have partners who are used to that. They have jobs who are used to that. They have therapists, they have psychiatrists, they have priests, they have everything. It's like living in a wheelchair and all of a sudden somebody comes and says, I know a new surgery. And none they stand up and say, wow, I can run. What a problem. Yeah? Why did I wait so long? Why did I have to wait so long? Why did I do 8, 9, 10 psychotherapy, which were insufficient? They get very angry on that. And you have to explain them why. And the other thing is simply, and now the partner is not used to that. My job situation is different. So this means you have to help them. And we have 8 hours just to cope with this new experience. That's a lot. Yeah? Partnership, occupation, social networks, all that change. Yeah. And now you can imagine why it takes a while. So data. We started, as I said to you, under residential conditions. That means for safety reasons. And these are the old data published. Here we have, we compared this 3 months treatment, 6 weeks after discharge, compared to a treatment as usual waiting list. Everybody was in treatment in these patients, some of them also at inpatient. Here you see about the profile. The mean age is 35. We are now applying this to adolescents. It seems as it works more or less the same. The start of the sexual abuse was 7 of age. About 50% had an ongoing abuse for longer than 5 years. The CAPS here is the CAPS 4. It's around about 90, which is extremely high if you look at the American studies. Usually they start at 60. So this is a very severe population. They have we said we want to study whether borderline patients work, so we didn't only include borderline patients, but we say we take them in. So we have in this sample, we have half of the patients have borderline, full-blown borderline criteria. So this is how it looks. The CAPS goes down 3 months after, 6 weeks after, this is half a year. This is half a year after discharge, down to around about 50 with an effect size of 1.4. And the funny thing is, if you look at only borderlines only, we find even a higher effect size of 1.6. The dropout rate here is 0. This is due to our capacity of residential treatment. So there's no difference between intent to treat and according to protocol, since the dropout rate is 0. The response and remission rate are 39, 38. And you see here, this is for those who do the borderline research, these are the effect sizes in the CAPS of the PDS, and here the BSL. This is 0.7. 0.7, if you do 1 year DBT, you have a reduction in the borderline symptom list about 0.6. So this is the first hint that you say, okay, it seems as if, at least at the comorbid borderline patients, targeting the trauma is as effective as providing them a specific borderline treatment. And the safety issues is we had about 60% cutters when we started. Within the first week, they went down to 20, and then they remained here. In week 4, we start with the exposure. On an individual level, we didn't see an increase of self-harm, not in one patient. And even the highly frequent cutters, they stopped it. And the urge for self-harm maintained, which is clear since this is a very strong conditioned assumption or idea. So, but it didn't increase. We had no increase there, and also it is not true for no increase in suicidal ideation. And this is my favorite picture. You see here the reduce of guilt and shame in this 3 months population. So we have 80% of our patients are within the normal range after 3 months of treatment. And they have been in treatments for 20 to 25 years in the average, unsuccessful. So this is what you can reach within 3 months. So then we said, okay, happy, it's safe, but maybe it's only safe under residential condition. It works, but maybe it only works for some reasons under residential condition. Maybe it's completely untypical. So next step, outpatient. We've rewritten the manual as an outpatient manner for 40+5, only individual therapy, and we compared this now with cognitive processing therapy. Paddy Resick supervised the whole thing, and we had 200 patients in it, multi-center trial. This is what is not published. It's fresh from the press. I have the data since 2 weeks. So you see here, we start here, and then we have every 3 months the treatments. So what we have figured out now is sample size is 200. We have only females here. Age is the same as an inpatient treatment. Here's the CAPS 5. This is a new CAPS. It's a little bit, it ranges from 20 to 70. The average is 40. PCL average 50. We have again, funny, 50% borderline patients. Our inclusion criteria were A, female, B, PTSD after childhood sexual abuse, C, at least 3 borderline criteria, including criterion 6, which is affective instability. So this means everybody had at least 3 borderline criteria. The average then was 5. The BSL, for those who are familiar, was 2, which means this is a very severe borderline population, and the GAF is 50, which means they were not that successful in their life. So this is the dropouts rates. The dark one is the DBT PTSD, the gray one is the cognitive processing therapy. You see significant differences. We are at 26, they are at around about 40. And if you look at and this dropout rate is not predicted by the treatment preference, so that's important. But it is predicted by the borderline criteria. So what you see here is the number of criteria, 3, 4, 5, 6, 7, 8, 9. We have only one with 9 here. And the red one is cognitive processing therapy, and the blue one is DBT. So what you see is that there's a linear increase here in the cognitive processing therapy of dropouts in borderlines. So that means the more severe, the more dropouts we have. And DBT does significantly better here. And if it comes to the real figures, you see here, this is the average. And here is the CPT. They lose about 50% of the borderline patients. And we lose about 30%, 33%. But even in the non-borderline patients, the dropout rates are lower. Yeah? That makes sense, since DBT is specifically designed to work with borderline patients. And we invest a lot of time in motivation and in the treatment relationships. So this is all the responses, the treatment responses. And of course, if you have the different dropout rates, you have to differentiate between intent to treat and according to protocol. And here you see the according to protocol, this means the completers, which are 75%. We have an 80% response rate here and a significant difference. And if you say the response criteria is 50% remission in the CAPS, we come down a little bit. This is the remission. This is the important issue. Remission means you don't show any PTSD symptomatology any longer. Intent to treat remission, more than 50% in the DBT PTSD, and complete remission, more than 80%. This means we can now tell our patients that you have if you stay in treatment, you have an 80% possibility that you are completely free of PTSD symptomatology, which is not that bad. And so we can do a lot of things. And the interesting thing, if you look at the curves, is that the major in the beginning, there's not that much difference, but then at T4 and T5, it splits up. And the point is that T4 exposure begins. So at least it's a hint that exposure seems to be an important issue. Yeah? So there's no significant difference here, but here it goes. Huh? And this is where exposure starts. Yeah, self-harm, highly significant reduction from 25% cut us down to 10. The CPT remains the same. They start a little bit lower. The GAF also significant better, the DBT part. It's not very good, but we hope and we are sure that the one-year follow-up will show a little better data. And the last slide is my favorite. This slide, I don't know whether you're familiar with explaining it. This means every dot is one patient. And here is the caps at the beginning, and on the left side, the y-axis is the caps at the end. This means, for example, this patient starts with caps of about 50 and ends about 60. So all these patients here on that line that didn't do any better. All these patients here did worse. All these patients here did better. And you see, there's not one patient who got worse. Neither in DBT nor in CPT. And I think this is the major one information. This is intent to treat. This means even the dropouts are in here. So this means there's no reason any longer to hinder our patients to go for a trauma treatment as soon as possible. So conclusion, only now that our data, we have 75% completers after 1 year. Treatment response, intent to treat 60%, completers treatment response 80%, the remission rate 50% or 80%. The CAPS in intent to treat is 1.4, the completer CAPS is 1.8. I don't know any treatment which provides your 1.8 effect size in this kind of severe pathology. And now that's also very important for all our thinking about borderlines. The BSL for the completer is 1.4. You remember the 3 months inpatient, we had 0.7. Now we have 1.4. And I don't know any treatment which is so effective for borderline patients, even that we didn't target borderline at all. So this is something where you could say, okay, it looks like, at least in this subpopulation of borderline patients who really have both, it is worth to take a risk and really go for it. So, thank you, and nice dinner.